And then we'll get. Okay, perfect. So again, if you guys missed the QR code, I'll show it again at the end. So no worries. But per usual, before we start, I have kind of the same reminders I've talked about last semester and at the beginning. Um, a lot of you guys I see at the library and I see you guys like writing everything out on the boards, and I'm like, yes, like those are my people. That's how I study. So I'm always there, always at the library, usually on floor 6. So I see some of you guys sometimes. Um, but yeah, I still totally recommend writing things out in the library or on the whiteboards in the library, like those meds or certain processes that are harder to comprehend. But at this point too, you guys have had like a solid semester of nursing school. So you know how you study best, and I'm not going to sit here and tell you how to study. I can just tell you what's worked for me in the past. And then yeah, per usual, get good sleep. I can't recommend it
Too.
enough.
Gotta do what I
Um,
gotta do.
Going to bed earlier and sleeping tends to have better outcomes than staying up later and studying, at least for me. But we'll go ahead and get started. I divided this the same way that your professors divide it. So we go through upper GI, lower GI, then I think it's liver, pancreas, gallbladder. So we're just going to kind of talk through the disorders and then the medications and what that kind of looks like moving through. So first is dysphagia. This is just difficulty swallowing. It's important to know the difference between dysphagia with a G versus with an S because they sound super similar. But dysphagia with the G is the difficulty swallowing. And for this course, we're talking about the causes being CNS lesions, like from a stroke, esophageal strictures, or things kind of restricting the ability of the esophagus to open, and then cancer. Next would be the hiatal hernia. This occurs when a portion of the stomach pushes up into the lower thorax. And it could also be considered a sliding hiatal hernia, meaning that like with movement or with digestion or inspiration, that hernia kind of goes up and out of the thorax, just depending on whatever physiological processes your body's going through. So hiatal hernias can actually be asymptomatic for extended periods of time. They're not like emergently life-threatening or anything like that. But if they do have symptoms, they're typically going to be things like heartburn, regurgitation, and dysphagia. Diagnostics then, X-ray, EGD, chest CT, and a barium swallow. Treatment, these look super similar for a lot of these. So I would be familiar with the treatments and what you do as far as like patient education goes. We're going to encourage sitting upright after eating, keep elevated at night, and then also small and more frequent meals as like people with hiatal hernias. GERD or gastroesophageal reflux disease is super, super, super common. It's also just like if someone has like a lot of acid reflux, they have GERD. Um, it's the most common disorder of the esophagus, and it's when those stomach contents, that super acidic gastric acid, goes up into, oh, are people not? If you're on here, could you go ahead and make sure you're muted? Thank you, Riley. My volume was down, so I couldn't hear anything. Um, yep, so that gastric acid is super, super acidic. It has a super low pH, and your stomach lining is meant to handle that and meant to tolerate that. However, the lining of your esophagus is not. It is not built to handle gastric acid. So when that acid refluxes up into the esophagus, you're going to get erosion, inflammation, irritation, and it can, I mean, in severe cases, it can erode all the way through the esophagus. So again, the esophagus just is not meant to handle those gastric contents. So the main symptom of GERD then is heartburn, that burning pain in chest. And actually, a lot of people come into the ED with heartburn thinking they're having a heart attack because they don't know the difference. Which is why when people say they have chest pain, it's super important to clarify and try to figure out if it's true pain or something like heartburn, which heartburn is true pain, but I mean like chest, heart pain versus chest pain. Diagnostics of GERD would be x-rays, scopes, kind of just using the patient history. And then treatment, you can go pharmacological or non-pharmacological. For non-pharm, again, it's those same things that we just talked about, avoiding those large meals, remaining upright after eating. If it's super bad, you can sleep with the head of bed slightly elevated. And then pharmacological, which we'll talk more about what each of these are. The main three classes are going to be your antacids, your H2RAs, and your PPIs. The one I see the most is probably going to be PPIs, especially in the inpatient hospital setting. Barrett's esophagus, then, this is when the lining of the esophagus is altered because of that excessive acid exposure, the gastric acid, gastric contents, which actually creates cellular variation. Super important to know that the Barrett's esophagus is a precursor to esophageal adenocarcinoma, which is cancer of the esophagus. So risk factors then are smoking, GERD, and obesity. And that makes sense because GERD, you have repeated chronic exposure to of the, sorry, you're exposing the esophageal mucosa to gastric contents repeatedly, which is changing that cellular makeup of the esophagus. Um, Manifestations, again, we're going to see GERD and heartburn. It's diagnosed by an endoscopy, so looking down there with a camera. And then treatment, you can perform ablation, well, not us, but providers can perform an ablation of the abnormal cells to lower the risk for cancer, and then also PPIs as a medication to work with that acidic nature of the gastric contents. H. pylori is a bacterial infection that is spread with contact and or exposure to emesis. And with most kind of contact infections, I guess, they can be consumed via food or water sources if something's contaminated on like a larger scale. With H. pylori, the goal of treatment is to eradicate the causative bacteria, so whatever bacteria is causing the infection. And H. pylori specifically is going to be treated with two different antibiotics given sequentially to reduce the risk of resistance and to just like ensure that that causative bacteria is eradicated. So again, acute and chronic, these show up all the time. To know the difference between acute and chronic gastritis, you do just have to have a general understanding of what it means to have something acutely versus chronic. Acute gastritis is acute inflammation of the stomach mucosa. It's featured by like sudden onset heartburn, nausea, vomiting, and anorexia or issues with appetite. And acute gastritis can be erosive or non-erosive. Erosive caused like by an irritant like NSAIDs, alcohol, radiation, whereas non-erosive is primarily that acute H. pylori bacterial infection. If it is erosive acute gastritis, you could also see blood in the emesis or stool. So that's something to kind of look out for. Typically, though, with acute gastritis, it's just one of those things that we kind of let run its course, depending on the severity. But chronic gastritis is chronic inflammation of the stomach mucosa that can be caused by kind of anything, repeated exposure to irritants, bacterial infections, or something surgical. The manifestations look a little bit different here. There's still heartburn and nausea and vomiting, but some differences would be excessive belching, early satiety, or halitosis, which is like that really foul breath. And it's like no matter what you do, you can brush your teeth, but the breath is more so coming from your stomach and your lower esophagus than your actual mouth. And with chronic gastritis, I would definitely know that there's a risk of B12 deficiency, which is also pernicious anemia, due to the loss of intrinsic factor from the consistent inflammation of the stomach mucosa. Treatment here, unfortunately, it's going to be just kind of a lot of those lifestyle modifications. There's not something we can do to just snap our fingers and make it go away. But we can also, treat the cause. So things like antibiotics for H. pylori or reducing that acidic environment through PPIs and things like that as well. Peptic ulcer disease. These are most commonly caused by H. pylori infections, but also NSAID/aspirin use. You learn in Patho 1 that those cause a lot of GI issues and put you at risk for, GI ulcers and bleeding. So putting those together, it makes sense for sure. In general, those clinical manifestations are going to be a burning, gnawing, and cramp-like pain. And there's a key difference between gastric peptic ulcers and duodenal ulcers. And I definitely would be able to identify based on symptoms where the ulcer probably is. A gastric ulcer is going to be experienced immediately after eating because it's as soon as that food hits the stomach, that ulcer is irritated. Whereas a duodenal ulcer, you're looking at the kind of start of the small intestine. So that pain is going to be experienced about 2 hours after eating when the food and contents start passing through that ulcer, the ulcered area. And it is more common actually than gastric ulcers to have it in the duodenum. Now, if these ulcers bleed excessively or perforate, so they open, that is a medical emergency because it means that the ulcer has eroded through all layers of the organ, the stomach or the small intestine. Um, Put it this way, if the stomach contents are that dangerous to your own esophagus, imagine if a hole just popped in someone's stomach and now those super acidic contents are just kind of leaking in their abdominal cavity. Like, it is not going to be good for your organs and bleeding and all those types of things. And then stress ulcers are also a very real thing. It's the reason why most patients who are inpatient are actually on PPIs like Protonics because the environment of being in a hospital, even if you don't have GI issues, that stressful environment and that change in your routine can actually cause an ulcer. So we give PPIs, H2RAs, et cetera, preventatively in those situations. Okay, here's our first question. Which of the following is true about H. pylori? And you can throw the answer in the chat. Awesome. Yep, you guys are all right. It's going to be treated with the two antibiotics sequentially for the sake of antibiotic resistance and just ensuring eradication of bacteria. Which of the following are characteristics of duodenal ulcers? Select all that apply. So I'm seeing combinations of the correct answers. Nobody put a wrong answer. It is going to be A, C, and D. Begins 2 to 3 hours after eating. That pain is also worse at night, and it is actually more common than a gastric ulcer. Okay, so here are the medications for the upper GI. For antacids, there are a bunch of different types. You have aluminum-based, magnesium-based, and calcium-based. I just put the most important adverse effect of each one to know there. So aluminum antacids can cause constipation, while magnesium antacids can cause diarrhea. And then your calcium-based antacids can cause hypercalcemia, which makes sense if you're ingesting excessive amounts of calcium-based medications. So just elevated levels of calcium. In general, including Mylanta, antacids work to raise the pH of gastric acid so that gastric contents will cause less harm in the event that they are exposed to the esophagus or, just places it's not supposed to be. It won't be so acidic and so detrimental. Simethicone is an antiflatulent that reduces gas, distension, and GI discomfort. So we can also give that if someone's having, excessive gas or just nausea, vomiting, those types of things. And for all antacids, you want to give 1 to 2 hours before or after other medications. Um, I actually just had a pharmacology exam today for ATI, and that came up all the time. Knowing that you can't give antacids around 1 to 2 hours before or after other exams, or before or after other medications is important to know. H2RAs, these are the histamine 2 receptor agonists. The prototype to know is cimetidine. Um, these are used to either prevent and or treat ulcers, as well as the symptoms from GERD or peptic ulcer disease. Can also be used for esophagitis or GI bleeds. Um, this medication, cimetidine, works by blocking the receptors that increase hydrochloric acid production, which in turn, by blocking those receptors, you're going to decrease the hydrochloric acid that's produced, ultimately reducing the acidic nature of the stomach. The adverse effects with cimetidine are super minimal if taken as directed, so that's a positive. Nursing implications here, it's important to give it at bedtime. There is an increased risk for pneumonia, and there are a decent amount of drug interactions to keep in mind. So prior to administering something like cimetidine, you would need to confirm, like just do a quick check, make sure that there are no drug interactions. And if you're not sure, you can always reach out to pharmacy or something like that to make sure that there's not a risk for an interaction there. PPIs, proton pump inhibitors, these are the ones I see the most, and that you've probably seen the most in clinical as well. The prototypes here are omeprazole and pantoprazole. Pantoprazole is Protonix. That's what they call it a lot because that's the brand name. It is the common first choice in these situations, and It works by preventing the release of gastric acid into the stomach. So you're going to have less acid with PPIs. So it's used again in peptic ulcer disease, gastritis, and GERD. But I bolded ulcer prevention because, again, we give it in the hospital to prevent ulcers a lot of the time if someone is at a higher risk for them. Nursing implications, Protonix can be given IV, that's that pantoprazole. And then again, PPIs are given in the hospital to prevent stress-induced ulcers. So the protectant you need to know is sucralfate. This medication I think is super cool. I feel like it's a little different than a lot of the ones we learn about. It works by forming a protective barrier on either healthy like lining mucosa or already ulcerated mucosa. It's not going to do anything about the gastric acid that exists in the stomach. It's just going to protect that lining and kind of act as a buffer against all the acid. Um, Sucralfate, another thing that's unique about it is it's not absorbed systemically, so its action is pretty limited to just the surface of the stomach. So there are minimal adverse effects. And then with sucralfate, you do need to give it about 2 hours before or after other drugs. So you're not going to give it with a, cup full of 10 other pills at once. You're going to give that one separately. For the prostaglandin analogs, the prototype here is misoprostol. And I'm not sure if you guys are quite there yet in maternal infant, but you're going to talk about this medication a lot there as well. Um, this one protects the gastric mucosa from NSAID damage. So it's typically taken with an NSAID if someone's taking NSAIDs like aspirin or ibuprofen repeatedly. You can take misoprostol to protect your gastric mucosa from NSAID damage, bleeding, and ulcers. The most important thing about misoprostol is that you cannot use it in pregnant women or women who might become pregnant or want to become pregnant. Misoprostol causes uterine contractions, so if there is a fetus there, they are at risk for miscarriage. The antiemetics, these are anti-nausea and vomiting medications. These work on the CTZ in the brain and the vomiting center to, again, prevent and treat nausea and vomiting. There's 6 different ones that we're going to talk about here. The first one is prochlorperazine. This is the prototype, and it's mainly used for chemo-induced nausea and vomiting. And in general, I'm not going to go into all the details with these. I did my best to like pull out the key information that I felt was super important about each one. But as long as you have a general understanding of how these work, if they can be used alone, and those side effects, you should be in a great place for the exam. So that's prochlorperazine. The next one is actually an antihistamine. This is hydroxyzine. So this one is actually used for like motion sickness induced nausea and vomiting. So if you're one of those people who, if you sit in the back seat, you're super nauseous, this is a type of antiemetic for that type of situation. But it can cause anticholinergic side effects. So again, think back to the last unit with those anticholinergic effects. So you can see issues with urination, bowel movements, saliva, what's another one? Vision, blurry vision, etc. Um, the 5-HT3 receptor antagonist, this is Zofran. Guys, this is the one that I feel like most people know. I've taken Zofran. It's a good antiemetic. The generic name is ondansetron. It's used for nausea, again, in many, many settings. I think it's pretty commonly prescribed. It does have some side effects. It could cause dizziness, headache, diarrhea and/or constipation, and increased liver enzymes. Corticosteroids. So these are those ones ending in "one," that suffix of ONE. So you have methylprednisolone and dexamethasone. These, because they're corticosteroids, they're not going to be used alone as an antiemetic. They don't typically, they're not going to act against nausea and vomiting by themselves. However, if you use them with other antiemetics, there's proven benefit from that in that reduction of nausea and vomiting. And again, I just put on there that corticosteroids in general can be identified with that ONE ending, which is helpful for the exam. Benzodiazepines, the prototype here is lorazepam. Again, these are not used alone as an antiemetic. However, if someone's nausea and vomiting is a result of anxiety or, panic disorders or things like that, lorazepam can reduce nausea related to that anxiety because it is primarily an anxiolytic or anti-anxiety medication. Lastly, these aren't necessarily medications, but these are just supplements. Two that are super common for nausea are ginger and or marijuana. Ginger interacts with the same receptors as Zofran does, so it can reduce nausea in that way. And then marijuana is often like, it would be considered medical marijuana, often used when other medications fail. Some people who are undergoing chemotherapy find marijuana super useful, but that would kind of be not something providers jump to right away to help with nausea and vomiting. Okay. Which of the following medications forms a protective barrier over ulcers? Awesome, guys. Yep, that one is a sucralfate. Your patient with a new prescription states that she's excited to be trying with her partner for their first child. Which medication order should the nurse question? Awesome, guys. Yep, that's that misoprostol. That's the one that can cause uterine contractions and ultimately miscarriage. Which medication blocks H2 receptors and in turn decreases hydrochloric acid production? This one's stumping some of you. Yep. This is cimetidine. The key in there is going to be the H2 receptors because cimetidine is the H2RA. Which of the following medications are not used alone as antiemetics? And then I put pick two on there. So there are two correct answers. Yep, you guys are right. Perfect. Okay, awesome. So that was everything for upper GI. I don't want to keep you guys super like late tonight, so I am just kind of going through things a little bit fast, but afterwards and tomorrow, if you guys have any questions, please feel free to email me because I'm always willing to help. But we'll move on to lower GI. The first condition we're talking about is irritable bowel syndrome or IBS. This is a chronic and functional disorder of the intestines. So if you look at them, nothing is going to be like objectively wrong with how they look or how they're functioning. Mainly characterized by spastic contractions in the intestine that impact peristalsis or that movement of contents through the intestines. IBS can feature constipation and or diarrhea, as well as abdominal pain, bloating, and distension. It's primarily diagnosed by, patient history and then ruling out other things. So maybe this person's had pain and diarrhea for months, and you've done a colonoscopy and you've done all these testing, and it's not anything else. It could be IBS. IBS is treated primarily by lifestyle modifications that could have positive effects on the GI system. But if someone has IBS-C, that just means that it's IBS featuring constipation. You could instruct them to increase fiber or take psyllium, which we'll talk about in a minute. That's a medication. And then if it's IBS-D or IBS featuring diarrhea, you can do antidiarrheals as a medication. Celiac disease, this one is an autoimmune response to gluten. So when someone with celiac disease eats gluten, that gluten causes denuding of the small intestine. Basically just means that the little, trying to think of the right word, the little like finger-like appendages in the small intestine that help absorb nutrients, they kind of die and they flatten and they lose that ability to absorb anything. Yep, gluten is going to cause inflammation. That inflammation causes denuding of the small intestine, making it unable to absorb nutrition or things from the food and or stool at that point. Manifestations here, you can have diarrhea, abdominal distension. The unique ones to remember would be a red and shiny tongue with fatigue and anemia. And all of these symptoms would occur after gluten consumption. And this isn't just like a little bit of a tummy ache. People who have celiac disease and if they accidentally eat gluten or something contaminated with gluten, they can be in excruciating pain for days. Like it is not something to take super lightly. I work in a restaurant right now, and we take gluten allergies very seriously, gluten like if someone has celiac disease or gluten sensitivities in general, we'll take it very seriously. The treatment here is going to just be a gluten-free diet. There's not like a medication we can give to stop the inflammation and the denuding, but if you avoid gluten, you're not going to experience these symptoms. So for the exam, just know some common gluten-free foods that you can recommend to patients. Secondary peritonitis is the inflammation and/or infection of the abdominal lining caused by the result of another organ being infected and/or perforating. So right under that it says when abdominal organs perforate, those contents can leak into the abdominal cavity, allowing for infection. The GI system responds to secondary peritonitis with hypermotility first. So you might hear hyperactive bowel sounds, maybe diarrhea, but then it will kind of revert to a paralytic ileus and things will stop moving completely. So clinical manifestations would be pain, abdominal tenderness is a big one, distension and that rigidity as well, alongside tenderness. And then also just signs and symptoms of infection in general. So you can have increased heart rate, temperature, and then a decreased blood pressure and urine output as well. Appendicitis, this is one we're probably familiar with just from our lives in general. This is inflammation or infection of the appendix, which is a little like appendage on part of our large intestine all the way at the bottom. It causes right lower quadrant pain, and a key like diagnostic thing you can do is rebound tenderness. I know you guys learned that in health assessment. So if someone comes in the ER, they have really sharp lower right quadrant pain, and they're positive rebound tenderness, we can't diagnose them, but you can expect that it's going to be appendicitis. Most cases, it is going to be treated surgically and then with antibiotics. If the appendix becomes gangrenous, which means if it's like the tissue's dying, or if it perforates, that also can cause secondary peritonitis. And in older adults, they might not actually display normal signs and symptoms of appendicitis, so they're at a higher risk for complications then because it can get further before diagnosed. Diverticulosis, and diverticulitis. Using the terms, you can kind of understand how they're different from each other. The diverticula themselves are small pockets of herniated colon. So the colon has an outpouching, essentially, is all a diverticula is. But if a patient has diverticulosis, they just have multiple diverticula. So maybe there's a part of their colon that just has all these outpouchings along the outside of it. That would be diverticulosis. But now, if those outpouchings become inflamed and or infected, that's diverticulitis. So typically it's going to be caused by food or stool accumulating within those pouches. So things like seeds and popcorn, those would get stuck a lot easier than some other foods, putting the patient at a higher risk for diverticulitis. Typically presents as lower left quadrant pain with tenderness and bowel irregularity. A complication here would be peritonitis. Again, if diverticula perforates as a result of diverticulitis, you can have peritonitis. In general, the best treatment is prevention. So just educating people on how to take care of their gastrointestinal tract, encouraging that high fiber diet, a good amount of fluids. And then if they already have known diverticula, teaching them those food triggers that could cause diverticulitis would be an important intervention. Intestinal obstructions, this is a blockage of the intestine that prevents movement of contents through the tract, either partially or completely. If it's a mechanical intestinal obstruction, there's actually a physical thing that is blocking contents from moving through. It could be a tumor, a hernia, a stricture, so kind of like a band around the intestine. Whereas functional would be kind of like the lack of peristalsis. So there's nothing blocking it, but your intestines just aren't moving things through like they should. It's characterized by distension, a wave-like kind of crampy pain, and then a failure to pass stool because, again, there's a blockage, so nothing's really moving through. And fluid and gas will actually accumulate prior to the obstruction. So when you're assessing them, you might be able to hear bowel sounds and maybe the upper quadrants, but if you get to the lower quadrants, there might be nothing. That would be indicative of an intestinal obstruction. Typically, you would give fluids. You do an NG for suction to get everything out from the obstruction up, and then surgery as well to take care of it. IBD, inflammatory bowel disease, is characterized by two things. There's Crohn's disease and there's ulcerative colitis. Crohn's disease is chronic inflammation of the GI tract that can happen anywhere in the GI tract, and it also can impact all layers of the tract. It's featured by small ulcers and patches of edema that can be seen with like colonoscopies that create a cobblestone-like appearance of the intestine. Granulomas can form, and as a result, the bowel wall becomes thickened, meaning that it also can't absorb nutrients as well as it should. And manifestations would be right lower quadrant pain, cramping after eating, and other systemic symptoms. Ulcerative colitis, then, or UC, is still IBD, just a different type. This occurs when there's diffuse inflammation and shedding of the colon. What makes this distinctive from Crohn's is that it can only impact the colon, the rectum, and the inner lining of the colon and rectum, so that mucosal layer. But still, like with Crohn's, it can cause thickening of the bowel wall and poor nutrient absorption, which is a recurring pattern between a lot of these lower GI disorders. And with this one, you're going to see lower left quadrant pain, cramping, diarrhea could have blood and or mucus, and then they could also be anemic as a result of poor nutrient absorption and also blood loss. If a patient has a lower GI bleed, you're going to want to assess what the blood looks like, because if it's bright red blood, it's going to be from lower in the tract, maybe the rectum or even external like a hemorrhoid. But if it's darker blood, it's likely from higher in the tract, like the small intestine or parts of the stomach even. Manifestations are going to be melena, abdominal pain, cramping, and they could also be hypotensive because they're losing blood. So again, you're going to treat cause, replace fluids, and give blood in this situation. C. diff, guys, this is a good one. If you haven't spelled C. diff yet, you will, unfortunately. C. diff is a bacterial infection that is often associated with antibiotic therapy because it is opportunistic. So if the body's immune system is already suppressed by antibiotics, your patient could get C. diff. C. diff is caused by bacterial toxins that damage the intestinal mucosa and causes excessive diarrhea. And I mean like excessive, nonstop diarrhea. You're going to treat C. diff with antibiotics, most commonly metronidazole or vancomycin. And C. diff, you're going to have a patient in contact isolation, and you have to wash your hands good. For C. diff, hand sanitizer is not enough. It's not going to work. So super important to know that difference there. Alrighty, here's a practice question. Jane Doe is a 22-year-old female who presents to the ED with new onset right lower quadrant pain. She rates it at an 8 out of 10. Upon assessment, her temperature was 101.9 and she was positive for rebound tenderness. What is the suspected medical diagnosis? Perfect. You guys did great on that one. That is B, appendicitis. Key things in there would be right lower quadrant pain, positive rebound tenderness, and also she's febrile. Your patient presents with right lower quadrant pain and complains of cramping after eating. The patient's colonoscopy reports come back detailing a cobblestone-like appearance. What do you suspect the patient has? Yep. That would be Crohn's. Again, key words there are going to be cobblestone-like appearance and that right lower quadrant pain. So for medications then, still talking about lower GI. For treating IBD, so Crohn's and ulcerative colitis, the goal is to reduce exacerbations because these are chronic conditions and also improve quality of life. There's an aminosalicylate, this is sulfasalazine. This is a medication that has a local effect in the intestines to decrease inflammation. So it could be taken PO or also rectally. And adverse effects here are headache, nausea, and diarrhea. Corticosteroids could be used again because these, as we know, reduce inflammation and these are inflammatory conditions. And then immunomodulators can be used because they alter the immune response, which we know is responsible for the inflammation. With immunomodulators, though, there's a lot more you kind of need to keep in mind. You would need to monitor your patient for pancytopenia, So kind of just low blood count in general, white blood cells, red blood cells, platelets. And then also because of that, they have an increased risk for infection. And then with immunomodulators, on top of the infection side of things and bleeding, you do also need to monitor their liver enzymes because immunomodulators over time can be toxic to the liver as well. The three antidiarrheal meds then, the first one is Lomotil or diphenoxylate with atropine. The major adverse effect here is tachycardia because atropine in the name is actually given to treat bradycardia, um, you know, objectively, so it can cause tachycardia. And with Lomotil, you want to educate the patient to stop taking the medication when the diarrhea is resolved. Bulk forming laxatives, the one we talk about here is psyllium. This works by absorbing water into gel to firm stool. That's why you take it with a glass of water. So it'll make that water gel and it'll interact with the stool and kind of make it more solid. And then lastly are the bismuth salts, which are chiopectate and Pepto-Bismol. These are over the counter. You can buy them, just at Walmart or Walgreens or wherever. They do contain aspirin though, which is important to know because if a patient has a history of GI bleeds or anything like that, that would be an important thing for providers to know. Also, if they're already taking aspirin for other reasons, it'd be good to know the actual amount that they're ingesting. And for the bismuth salts, it's important to know that it causes harmless darkening of the tongue and stool. So if a patient comes in kind of freaking out that their tongue is turning dark, you can educate them that that is a expected finding of something like Pepto-Bismol. What are some nursing considerations for a patient who is on an immunomodulator for IBD? Select all that apply. Okay, I think I'm tricking some of you guys. It's all of them, so you're all right in a capacity. You're going to want to instruct visitors to wash their hands because this patient is at a higher risk for infection. So you're going to kind of initiate all those infection prevention protocols like washing hands, monitoring for pancytopenia, and signs of infection. Almost all of you said those two, B and D. And then C, immunomodulators are also liver toxic, so you do have to monitor the liver enzymes as well. Which of the following medications causes harmless darkening of the tongue? Awesome. Yeah, you guys all got that one. That is D, that kaopectate, which is one of the bismuth salts. Alrighty, next is the liver. It's not in the PowerPoint, but I would recommend reviewing the general functions of the liver and just like the lab values like ALT, AST, because it'll help you understand some of the pathophysiology that we're going to talk about. So first is liver failure. With acute liver failure, there is an 80% mortality that we associate with it. It involves massive necrosis of liver cells, which just means death of the liver. And it's actually most commonly caused by acetaminophen toxicity. So, overdosing on acetaminophen or taking it for extended periods of time. But there are also other causes like drug reactions and viruses. Signs and symptoms, before I say these, definitely know these for liver, pancreas, gallbladder because they're super similar and they're going to be on the exam, can almost guarantee it. And it's super important to be able to identify these and provide patient education. So key thing you're going to see over and over again is dark urine and light stool or like clay colored stool. That's a key characteristic of liver failure. And then also right upper quadrant pain can be there because that's where your liver is. Late signs and symptoms, though, are going to involve things like hyperventilation, respiratory failure, hepatic encephalopathy, which we'll talk more about, and coagulation issues. So those are more, we're looking at the functions of the liver and how those are impairing the rest of the body. So non-alcoholic fatty liver disease is a chronic liver disease that's caused by the fat accumulation within liver cells. The signs and symptoms are the same as liver failure. And the risk factors for this one are obesity, high fat consumption, type 2 diabetes, dyslipidemia, and hypothyroidism. Whereas AILD is alcohol-induced liver disease. So you still have a fatty liver disease, but this one is caused by alcohol. Alcoholic hepatitis then is between fatty changes and cirrhosis. So you can get alcoholic hepatitis after an abrupt increase in alcohol. And then alcoholic cirrhosis is when blood flow and bile flow are disrupted because of cirrhosis of the liver or an excessive amount of fibrous non-functional tissue. So cirrhosis then, which I just mentioned, is end-stage liver disease where fibrous scar tissue replaces functioning healthy liver tissue. That fibrous tissue is going to restrict biliary and vascular flow, so bile and blood. And it also just isn't going to work like normal liver tissue should. So you're going to see decreased clotting ability, thrombocytopenia, ascites, and portal hypertension. Hepatic encephalopathy is a life-threatening condition from severe liver failure. So it presents pretty similarly to liver failure. And it occurs when the liver can't detoxify the blood. And when this happens, there's an increased amount of ammonia in the bloodstream, and that ammonia is what's causing the encephalopathy. The main medication for hepatic encephalopathy is lactulose. This one works by binding that excessive ammonia in the bloodstream to the stool. So when you then poop, you're getting rid of the ammonia through your stool, bringing that down to a normal level. The goal here is to have your patient have 2 to 3 soft but formed stools a day. Jaundice, there are 3 types that we talk about. The most important one per your study guide is obstructive jaundice. So this occurs when there is an obstruction outside the liver, kind of hindering biliary, like bile flow because of gallstones. Jaundice typically just presents as that yellowing of the skin and of the sclera. I would know all 3, but for the sake of time, your study guide does say obstructive jaundice is the most important to know. Portal hypertension then, this is increased pressure in the portal venous system, which is associated with cirrhosis. So we're talking about the vascular system of the liver now, which can cause 2 major complications being ascites and esophageal varices. If someone has portal hypertension, you're going to treat it with things to lower that pressure, like beta blockers and or diuretics, because you're going to try to prevent ascites and especially esophageal varices. Ascites is the buildup of fluid inside the abdomen. I'm sure we've all seen this. They have like a super enlarged abdomen and it's like taut, and sometimes it doesn't look proportionate to their body. With ascites, you're going to monitor their weight and girth daily. And spironolactone here is the drug of choice for ascites. It's that diuretic, that potassium-sparing diuretic. So that's the one we're going to want to give here. You're still going to work on fluid and electrolyte replacement, and you're going to want to monitor for changes in level of consciousness. The other thing is a paracentesis, which is essentially just draining that excessive fluid from the abdomen. And they can do that bedside in the hospital as well. It's not like an invasive surgical procedure. Esophageal varices then are dilated blood vessels in the esophagus from portal hypertension. So now we're inside the esophagus, and these blood vessels are big, meaning that they're dilated and they're weaker. So if those blood vessels rupture, you can bleed a lot. You can bleed a lot and you can go into shock. And even worse, the liver is responsible for a lot of clotting factors. So if your liver isn't working and you've gotten to the point that you have esophageal varices, you probably can't clot very well either. So now you have these vessels in your esophagus that ruptured, and now you also can't clot. So it's a pretty bad situation. Octreotide is the medication to know for this because it causes vasoconstriction with the goal of reducing bleeding. So those vessels that burst, it's going to restrict them and prevent the amount of blood loss. But again, really preventing getting to this point is the big key. And if someone, again, does have portal hypertension, you can work to prevent esophageal varices with things like antihypertensives. Hep A and Hep B, these are liver inflammatory infectious conditions. Hepatitis A is spread the oral fecal route, and it's an acute disease that oftentimes recovers without treatment, kind of self-limiting. Hepatitis B, this is the one that we do all of our like titers for. This one is the one that's spread through blood and bodily fluids. So there's an increased risk in IV drug users and healthcare workers, again, because you're working with needles. in general. That's a risk that our profession carries. Only 10% of people with hepatitis B develop like chronic issues like cirrhosis, but it can be pretty serious. So once a patient is symptomatic with hepatitis B, you're going to start antivirals, that PEG interferon, and then tenofovir disoproxil or entecavir. These are just different antivirals for hepatitis B. C, D, and E. D and E are talked about a little bit less, but hepatitis C is the most significant one that mainly spreads through blood and bodily fluids, just like hepatitis B. It is more common, and it's actually the most common cause for liver transplant. Um, Before transplant, or if someone's not having a transplant, they're going to be treated with 2 or 3 antivirals at the same time. Hep D is a serious infection that requires a simultaneous infection of Hep B. It's like a super infection. So Hep B and D pair together to kind of make each other worse. And then Hep E is another fecal oral transmitted infection. And it's actually endemic in India, Asia, Africa, and Mexico. So that's just kind of a thing that is occurring regularly there. What is the drug of choice to treat ascites? Awesome. Yep. D, spironolactone. Which of the following are characteristics of liver failure? Select all that apply. I want to see what you guys come up with, but I think there are 4 right answers. Yeah. I saw a couple di different answers, but I think the majority of you guys got it right. Dark urine, light stools, jaundice, and then knowing that it's most commonly caused by acetaminophen toxicity. Fatty cells would not be characteristic of liver failure. That would be like non-alcoholic fatty liver disease or something like that. And then liver failure is actually pretty fatal with a high mortality rate. What types of hepatitis are spread via infected blood and bodily fluids? Select all that apply. Yep. B and C. A and E are going to be that fecal oral route. Perfect. Okay, gallbladder and pancreas. Lucky for you guys, there are no medications here, so that's super huge. For this exam, most of the medications do come from upper GI. So gallbladder and pancreas, just understanding that pathophysiology, which, correct me if I'm wrong, but you most likely learned about this today. So the gallbladder is referred to with the prefix chole. So if you see chole something, you're talking about the gallbladder. The gallbladder is the organ that secretes bile through the cystic and common bile ducts into the duodenum. And bile is a substance that digests fats. So that's just kind of like the physiology of the organ itself. Cholecystitis, then, kind of using words here, that ending in itis, we're going to be talking about inflammation. So it's inflammation of the gallbladder. If it's acute, it can be caused by obstruction of the ducts, like by gallstones. It's going to have that fast onset and it can have fever and nausea and vomiting with it. Again, those acute characteristics. And you do have to kind of act fast with acute cholecystitis with antibiotics or removal of the gallstones because the gallbladder can become infected and perforate, which would then put the patient at risk for secondary peritonitis. Chronic cholecystitis would be defined by repeated episodes of cholecystitis, so that acute. And it's consistent with vague signs and symptoms, like a fatty food intolerance, belching, and a colicky kind of come and go pain. And the treatment for chronic cholecystitis is going to be rest, fluids. They can be NPO to limit symptoms, and then also a cholecystectomy or ultimately removal of the gallbladder. Because the gallbladder is not a life-sustaining organ. You can live without one. A lot of my friends actually have had theirs removed. And it would just change the way that your body digests things because you're losing that route of bile, essentially. Cholecystitis can be caused by stones, which would be calculus cholecystitis, which is about 90% of the cases. But just like anything in your body, you can also have inflammation and or infection without something like stones. So that's like the other 10% of cholecystitis cases. Cholelithiasis then is the fancy word for gallstones. These can either be pigment stones or cholesterol stones. Pigment stones are when parts of the bile separate out and harden and form stones, and these ones do require surgical removal. Cholesterol stones is when the cholesterol itself in the bile forms into stones. Clinical manifestations are going to be pain in the right upper quadrant with colicky pain, precipitated by a fatty meal because the gallbladder, when you digest fat, wants to push out as much bile as possible, but the stones are blocking that from happening, causing pain. And again, you're going to see jaundice, dark urine, and gray stool. It's like a fun trio to watch out for. Treatment here, rest, NPO, antibiotics, low fat. Um, an important thing to understand about cholelithiasis and stones in general is they're not easily treated with medications. There are only two medications that are currently available and approved to work for stones, and even then, they only dissolve cholesterol stones, so they're not going to work on pigment stones, and they can take up to 12 months to work. So if someone is having acute issues from stones right now, telling them to take medication that might work in 12 months is going to be hard to for them to hear. That's not what they want. So most of the time, if it's serious, they'll get their gallbladder surgically removed. Cholestasis then is the impaired bile flow from the liver, which could be intrahepatic problem, meaning there's a problem within the liver that inhibits the secretion of bile, or extrahepatic, meaning that there's a problem in the bile ducts outside of the liver that restrict the flow of bile through those ducts for whatever reason. So as a result, bile backs up because it can't get through like it wants to, which causes inflammation in the liver, gallbladder, and pancreas. So cholestasis is just saying like static bile movement, essentially. Acute pancreatitis, then, this is acute inflammation of the pancreas. Most of the time, it's caused when premature production of pancreatic enzymes kind of destroy pancreatic tissue, which could be caused by bile duct obstruction as well. 80% of cases are related to alcohol and or gallstones. And if it's mild or acute, you might have inflammation of the pancreas with kind of minimal organ dysfunction. But now if it's severe or, you know, yeah, if it's super severe, you can actually have tissue death of the pancreas and surrounding tissue. You can have blood vessel damage, cysts, abscesses. It can perforate, risk of systemic complications, and severe acute pancreatitis can actually be very emergent. So with that, you can have sudden pain in the abdomen, sudden pain after a meal that's kind of hard to localize. So your patient might just say it hurts everywhere. Jaundice. If they have bruising around their umbilicus or belly button, that's typically indicative of a severe case of pancreatitis. And then as it progresses, the patient is at risk for shock and hypovolemia, which would be evidenced by things like tachycardia, hypotension, cyanosis, and cold clammy skin. So NPO, NG suction, fluids to prevent hypovolemia, pain meds because pancreatitis is very, very painful, and if necessary, surgery could be done. Chronic pancreatitis is often undetected. It goes undiagnosed or missed. Typically, over 90% of cellular function is already lost before any symptoms appear. So the pancreas is kind of pretty far gone at this point when a patient's diagnosed with chronic pancreatitis. So those functioning cells are replaced by non-functioning fibrous tissue. Same thing that kind of happens in liver cirrhosis. And the common cause here is like long-term alcohol abuse. So chronic pancreatitis would be seen in your like lifelong alcoholics or people who have substance use disorders. Diabetes 3C is when you develop diabetes um, because of a pancreatic disease like pancreatitis versus type 2 diabetes, which you learned more about last semester, but it's just a different causative agent of diabetes. But you would treat it the same as type 2 in general. Why is medication for gallstones not ideal? And this is kind of a fill in the blank, so I don't have options for you guys. So just throw what you think in the chat, and I put possible answers on the next slide. Yeah, Yep, that is definitely one of the most common reasons. I put down there are only two currently that we have accessible. They take 6 to 12 months to work, and they only work on cholesterol stones. So they're not going to work on those pigment stones that people could have. What are some signs and symptoms of cholelithiasis? Same thing. I didn't do multiple choice. I had to switch it up a little bit. Sorry, I'm playing with the clock. Sorry, guys. I'm seeing some good answers come in. Yep. Right upper quadrant pain, nausea, vomiting, light stool, jaundice, perfect. Yep, I put some options in there. Everything you guys said. Yep, perfect. You guys got that. In a patient diagnosed with acute pancreatitis, what does bruising around the umbilicus indicate? Yep, that would be signs of a more severe case of pancreatitis. Okay, perfect. Wow, I was starting to rush because I didn't think I was going to be done in time. That is everything I have for you guys. I'll throw this back up in case you missed it at the beginning. I have, like I said, a document with 10 practice questions on there for you as well. And then tomorrow, I do have clinical, but I'll be back in town around 5. So if anyone has any questions or wants to chat about exam content, I would be happy to be a resource for you guys. So good luck on Thursday. You guys are all going to do great. And thank you for engaging and interacting tonight. I appreciate it. I'm going to stop recording.